This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 986, recorded on February 23rd, 2023. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today, about 50 miles north of Venezuela, Daniel Griffin.
Hello, everyone.
What does it mean? It's not in Venezuela, it's in another country?
So it actually is in another country. I'm on an island about 50 miles north. It's actually the Dutch Antilles. So yeah, beautiful, beautiful spot.
All right, let's get going before the internet dies.
Yeah, we got a lot to do. So let me start off with my quotation. This is from John Steinbeck from East of Eden. An unbelieved truth can hurt a man much more than a lie. It takes great courage to back truth unacceptable to our times. And maybe people will realize later on why I picked that quotation. But we'll talk a little bit about RSV first off. A couple exciting articles this week. And the first one was Respiratory Syncytial Virus Prefusion F Protein Vaccine in Older Adults, published in the New England Journal of Medicine. I hope everyone's excited already just hearing that title. But these are the results of an ongoing international placebo-controlled phase 3 trial where they randomly assigned in a 1-to-1 ratio adults 60 years of age or older to receive a single dose of an adjuvanted RSV prefusion F protein-based candidate vaccine or placebo before the RSV season. And I want you to be thinking about a timing issue here and how that might be translated into the future. The primary objective was to show vaccine efficacy of one dose of this vaccine against what? RSV-related lower respiratory tract disease. Not infection, not PCR positivity, but RSV-related lower respiratory tract disease. And this had to be confirmed by RT-PCR. So here we have vaccine efficacy for PCR-confirmed lower respiratory tract disease. Efficacy against severe RSV-related lower respiratory tract disease and RSV-related acute respiratory infection also assessed. And they also did some other analysis, including looking at safety. They had almost 25,000, so 24,966 participants received one dose of the vaccine or placebo. So 12,467 participants got vaccine, 12,499 got placebo. They followed them, median follow-up of about 6.7 months, and the vaccine efficacy against the RT-PCR confirmed RSV-related lower respiratory tract infection was 82.6%. The vaccine efficacy was 94.1% against severe RSV-related lower respiratory tract disease. And this was assessed on the basis of clinical signs or by the investigator. And interesting, I will include this, 71.7% against RSV-related acute respiratory infection. They did report that the vaccine was more reactogenic than placebo. I think people know what reactogenicity is at this point. But most adverse events for which reports were solicited were transient, were mild to moderate in severity. The incidence of any serious adverse events and potential immune-related disease, similar in the two groups. We're not seeing any kind of a safety signal there. And it's pretty robust, talking about over 12,000 participants getting the vaccine. Just a little background here. This vaccine is an adjuvanted protein-based vaccine that creates an immune response against the RSV F glycoprotein, which mediates viral fusion and host cell entry. The protein is, they say, highly conserved across the two RSV subtypes, A and B, and the vaccine contains an F protein stabilized its pre-fusion conformation, which exposes epitopes targeted by neutralizing antibodies. And then just a little bit more, the AS01 is a liposome-based vaccine adjuvant system containing two immunostimulants. MPL and saponin QS-21. And it's got a nice Kaplan-Meier curve showing, the cumulative incidence over time. And they talk about following them out for a certain period of time, but the RSV season kind of ends, right? So then you just have nothing new in either group. So I don't know. Any comments there, Vincent?
I think in Idaho, they're getting ready to pass a bill making it illegal to use this.
No, this is protein based. This will be okay.
Oh, okay. I see.
This will be okay.
Oh.
So, yeah, no, I mean yeah, we'll probably circle back to that. But yeah, there's a bill in Idaho, and I had a couple comments about it, but it's a really broad-based bill where they want to take away people's access to anything that's mRNA based, and so legislators jumping in and taking away the freedom for individuals to make a decision about the health for themselves, the health of their children. Yeah, not so ideal, but yes, this is protein based, so it'll be okay. Okay. We also have the article Efficacy and Safety of an Ad26 RSV pre-F protein vaccine in older adults. It's a little bit more complicated, so we'll try to sort this out. But these are the results of Cypress, which is a randomized, double-blind, placebo-controlled phase 2b proof of concept trial to evaluate the efficacy, immunogenicity, and safety of an adenovirus serotype 26 RSV vector encoding a prefusion protein, prefusion F protein, in combination with an RSV prefusion F protein. So a little more complicated here, and I was sort of wondering, why did that other one get the spotlight in the New England Journal? This one's sort of off to the side, but this is phase 2b. We only have 5,782 participants enrolled and receiving an injection, vaccine or placebo. So here again, they're looking at vaccine efficacy for RSV-mediated lower respiratory tract disease. And here they're reported vaccine efficacy of 69.8 to 80% for different case definitions. And again, seeing really no concerning safety signals here.
So Daniel, these are for adults. What about the babies?
So interesting. There's, we're not covering it today, but there's a lot in the works for potentially vaccine for women who are pregnant, individuals who are pregnant, and then potentially having that protection. And also there is some ongoing work for pediatric vaccines. So exciting stuff, because as we've talked repeatedly, RSV is a problem really for the extremes of age. So the first few years of life in particular, and then the last several decades of life. All right, Marburg. So not a lot, actually. As of the morning of February 17th, and that's like a week ago now, getting this data from the U.S. Embassy, there have been no new confirmed cases of Marburg virus disease in Equatorial Guinea or the surrounding countries. I'm waiting for any kind of more recent update. And as I mentioned last time, those two suspected cases that crossed the border into Cameroon, suspected, tested negative for Marburg as well as Ebola. So more to come or not. Norovirus, still on the rise. I think I talked to last week when we were in the sort of 12, 13, 14%. We're now up at about 16 or more percent. So norovirus is still rising. So wash those hands. Okay. All right, COVID. So let me start with the issue of COVID vaccine mandates in healthcare settings. This is a nice article by David A. Lieb and Kavish Harjai. Healthcare vaccine mandates remains as some push for an end, published in the AP, the Associated Press. Now, it's really interesting. I mean, people should read this article. But, there were several facilities they talk about where, these factors showed up and they said, half your people working here are not vaccinated. What's going on? We'll be back in 15 days to check in and make sure they've all, complied with our mandates. So what did the employers do? They actually just wrote them all exemption letters. Now, some employers are suggesting it's hard to staff their facilities unless they are allowed to hire anti-vaxxers. There's a side to this which is really difficult. I'm going to tell a little bit of a story here. It's in the pandemic, And I think as I related, I would do these educational sessions each day. So at 1 o'clock, I would appear on One East, and all different providers, nurses, et cetera, would gather, and I would go through, the latest updates and also any challenging cases. Hey, let's discuss them. And I would do a similar thing in the ICU. First thing in the morning, I'd come in and we'd sort of run through the 20 or more patients that were in the ICU, discussing their care as well. What were some, the latest updates? And periodically there would be advances in the vaccines. There would be results from trials. I would discuss them. Actually, one of the nurses was clearly anti-vax, actually complained to the medical director, and in so many words, do I have to listen to all this stuff about vaccines when I'm just here to do my job in the ICU as a nurse? Really challenging. When people come to the hospital, I think there's an expectation that they're going to get evidence-based, science-based care, that we're not just going to be waving hands and, dictating care on the basis of anecdotes. So it is a challenge when suddenly, this influx of anti-vaxxers who feel validated are brought back in. So just trying to add another dimension to all this. Okay,
Why do they feel validated, Daniel?
So it is an interesting dialogue, but a lot of people have held out, have left the workforce and have not worked because they were against vaccine. And now if they're hired back, without having to be vaccinated, there's a validation. There's, okay, now it's okay. All right, the article, Past SARS-CoV-2 Infection Protection Against Reinfection, a Systematic Review and Meta-Analysis published in The Lancet. This got lots of strong reactions on Twitter. And I think many are reacting to the media headlines, and I just don't know how many people have actually read the article, particularly those that are using it as a confirmation bias of their position. But let me go through this article and share what it actually does say, as well as the implications. So this is a systematic review and meta-analysis. So this isn't an actual study. This is taking a whole bunch of studies and putting them together. And here they identified, reviewed, and extracted from the scientific literature retrospective and prospective cohort studies and test negative case control studies published up to September 31st, 2022. That estimated the reduction in risk of COVID-19 among individuals with a past SARS-CoV-2 infection who survived, right? You got to do that. You got to survive to be in this study, in comparison to those without a previous infection, symptomatic disease, and severe disease. So they included 65 studies from 19 different countries. Their meta-analysis suggested that protection from past infection for symptomatic disease was high for ancestral, alpha, beta, and delta variants, but was substantially lower for BA.1. Now, this is, I think, the number to sort of look at it and ask, what sort of judgment would you put on this? So the estimated effectiveness was 44% against Omicron BA.1 symptomatic disease. Now, protection against severe disease remained high for all variants, with 90% for ancestral, alpha, and delta variants, 88.9 for Omicron BA.1 at 40 weeks. So what do I have to say? So I think the data is not surprising. The conclusions and interpretations here seem odd. There's a physician out west who either has issues communicating science or is not getting the big picture here. Let me quote, I've been considering a COVID infection to be the equivalent of a booster in terms of protection against reinfection and severe disease, hospitalization/death. These study results indicate that it is at least that good, maybe even a bit better. Are we going to ignore the hospitalizations, the missed work, the deaths, the suffering, and long COVID? Did this person really mean to endorse getting COVID as the safe option to prevent you from getting COVID? Vincent, I thought you might have run across these conversations.
Yeah, this has been discussed as a validation for getting infected, which is crazy because, as you say, you could die. More likely to die than if you're vaccinated. So it makes zero sense. And if this person is a physician, they need to go back to school.
They might be a little too old for that at this point, but it's really tough. I mean, the interpretation here, I think it has to be careful because if you look at this and you don't communicate properly, you're encouraging, oh, just go ahead and get infected, and then that'll protect you against getting infected. But wait, why do you not want to get infected? It's because you could die, you could end up with long COVID, you could end up in the hospital, you could miss work, you could have ongoing problems. So getting COVID is not the safe option. Vaccine is. All
Let's
right,
put
so
it
let's
another
move.
way, Daniel.
Yeah,
So look at it this way: you get a vaccine, and then you're ready to go with immunity. If you get infected, you have a memory response that kicks in a few days. If you're not vaccinated, you get infected. It's a crapshoot whether you're going to get really sick before your immune response can control the infection. And so that's a very clear scientific justification for vaccination. It just, I don't know why they would even do this study unless they're just interested in, the scientific basis for the comparison, because it gives people fuel for saying, yeah, I'm going to get infected as a way of being protected.
yeah. I mean, I think it's important probably to focus on the numbers too, as we've been saying. If you get your 3 shots, you have this 90% durable protection against severe disease, and you get it without risking getting severe disease
Right.
in the process. Yeah, and I think if you're going to say like, oh, those vaccines, I hear they don't work, well, then what you're talking about is protection against infection, and 44% for a number of months against BA1, which isn't even here. We have more immune evasive. So, yeah, if you can, if you compare your apples and oranges, you can get better apples and oranges more safely. So, all right. I was going to do some tree climbing analogy there, but anyway, all right. So, pre-exposure period, transmission, and testing. The big thing here is have a plan. And as I say about those masks, you know what? If you don't wear them, they don't work. And I'm not sure we need to do a study to prove that. Just telling people to wear a mask. If they don't wear it, it ain't doing anything helpful. All right. COVID active vaccination. I guess there's going to be some mRNA technology in here. So, those of you in Idaho, if you want to continue to have choices with regard to your healthcare, if you're maybe opposed to having politicians take away some of those, just pay attention. But another preprint, third vaccine dose equalizes the levels of effectiveness and immunogenicity of heterologous or homologous COVID-19 vaccine regimens. This was posted, and I think it's important to make sure you think about this. So these are the results of an observational study of SARS-CoV-2 infections among vaccinated healthcare workers at the University Hospital of Lyon, France, with an analysis of immunological parameters before and after the third mRNA vaccine dose. So they reported that following the second vaccine dose, heterologous vaccine regimens were more protective against infection than homologous. So let's just sort of lay out what they're doing here. So they're looking at individuals that stuck with Team Moderna or stuck with Team Pfizer. They got their 2 shots, and they compared to people that mixed and matched. And you actually, if you follow out the cumulative COVID-19 incidence, you actually see a separation. But then when you actually get to the third dose, no longer the case. So whether you got that, and I think we've been saying for a while, it's a 3-dose vaccine now with the newest variants. When you get to 3 doses, it really doesn't matter. And you can see, really nice curve here, cumulative COVID-19 incidence, that heterologous, homologous, really very similar. Okay. Moving on to COVID early viral upper respiratory phase. So remember, and I think it's really important, there are multiple phases to COVID, right? So, and we've labeled these, we've described these for, about 3 years now. So there is the early viral upper respiratory phase, right? This is when there's really high RNA copy number, low CT values. This is where you have the window of greatest opportunity to jump in with your antivirals. Number 1, Paxlovid. Number 2, remdesivir. Number 3, monoclonal antibodies. And now with the variants, we have quite a bit of challenge. This I thought was really interesting, this study I'm about to discuss, this preprint, where we've always looked at the neutralization, and said, oh, well, if it can't neutralize, well, then that's the only measure of antibodies efficacy. So in this preprint, Sotrovimab retains activity against SARS-CoV-2 Omicron variant BQ.1.1 in a non-human primate model posted on bioRxiv. And that's, it's all in the title there. So these investigators report efficacy of Sotrovimab against this BQ.1.1 viral replication as measured by RT-qPCR in a non-human primate challenge model. And they actually have some really nice graphs. We can actually see the decay of the Sotrovimab concentration over really the first few days when it's administered. And then they actually have a challenge where they're looking at the viral RNA in the trachea, they're looking at viral RNA in the bronchoalveolar lavage. And, maybe people take a look at this, but it's really nicely color-coded. So those that got Sotrovimab are in blue, and you really see no viral RNA in the trachea or BAL. But the controls, you actually see pretty high viral RNA copy numbers in the trachea and the BAL. So really interesting, and I think it's sort of been that warning for us. It's really tough. I mean, we think things don't work when we lose that neutralization, but we've talked a lot about FC-mediated activity. Not sure how you really use this operationally to decide whether or not you can continue using these antibodies unless you're going to go ahead and start sacrificing or using these primate models.
Yeah, you have to do it in people. If you have a variant that you think is going to be around for a while, you do a small trial and see if it helps, right?
Yeah. And it's a challenge, right? Because you probably have those people on Paxlovid or Remdesivir.
Sure.
But there are people that can't get those. So, those people could be in a trial like this.
It would be really great if we had some correlates for non-neutralization, FC and so forth, but they're hard to do. So it's a challenge, as you said.
It's a call for setting up those assays, right? Some FC-mediated. All right, molnupiravir, we say last and least. At some point, we're going to hear an update on the limited role of convalescent plasma. But a little bit of time today on avoiding those harmful and useless things. So this is where we generate our hate mail today, Vince, and I just wanted to warn you ahead of time. It's one of those things, and I like to think of it as common sense. There aren't things that you just know are true. You have to actually take a look, right? Before I came to this island where I am right now, I look at some pictures, I can read about it, but if you actually take a look, you're not sure, like, is the water going to be clear and nice? What are the people like, et cetera, et cetera. And that's all science really is. It's just, let's take a look and let's actually see what's true. And so early on, as we know, a lot of people were very excited, shall we say, bullish about ivermectin. And we honestly did not know. And so we went ahead and we did a number of trials. And one of those was this repurposed drug, the Activ-6, really asking the question, and here we have the article, effect of higher dose ivermectin for 6 days versus placebo on time to sustained recovery in outpatients with COVID-19, a randomized clinical trial. This was published in JAMA. So these are the results from the Accelerating COVID-19 Therapeutic Interventions and Vaccines, the Activ-6 study group and investigators. I know if you're following the science, you're perhaps saying enough already, asking how much this study cost the U.S. taxpayers. If you are pro-ivermectin of the school that some things you just know are true, then much like that Father Mary Poppins, I hate to confuse the situation with facts, but here we go again. Unlike a Cochrane meta-analysis that is far from a gold standard, this is a double-blind, randomized placebo platform trial looking at whether ivermectin with a maximum targeted dose of 600 micrograms per kilogram daily for 6 days compare with placebo would shorten symptom duration among adults equal to 30 years of age or older, outpatients with symptomatic mild to moderate COVID-19, right? So they're getting in this early during that viral replication period. They included 1,206 U.S. adults with COVID-19 during February 2022 to July 2022. The median time to sustain recovery was, drumroll, 11 days in the ivermectin and 11 days in the placebo group. Those seem exactly the same. In the ivermectin group, 1 participant died and 4 were hospitalized. In the placebo group, 2 participants were hospitalized, no deaths. Adverse events were uncommon in both groups. And the statisticians tell us that in this largely vaccinated 84% population, the posterior probability that ivermectin reduced symptom duration by more than 1 day was less than 0.1%. So there's still some hope, Vincent. There is a 0.1% chance that ivermectin really is helpful.
It's not worth it, Daniel.
We have millions of dollars. We could move more from the budget for education and other things and continue to study ivermectin, this antiparasitic. All right. COVID, early inflammatory lower respiratory hypoxic phase. Now, I'm going to soapbox here for a second. Maybe it's because I've gotten a little downtime, but let us return to the original terminology and stop calling this the rebound stage. No rebound here. As Vincent and I have discussed repeatedly, the viral RNA is dropping from the original high. People do start testing. They have a period of negative and positive test results because they're right at the edge of detection. They're not shooting up to these like tens, hundreds of millions of RNA copy numbers. They're fluctuating in the 30s. That's not a rebound. After the improvement in the viral symptoms, a chunk of people start to feel worse with the onset of the cytokine rise and the ramping up of the immune response. If one got treatment in that first week and were vaccinated, there's really nothing foreboding here. Watch those oxygen levels. There is no evidence that more antiviral medication will be helpful. Remember, this is the early inflammatory. This is not a second viral replication phase. There is no rebound here. All right. What do we do if we miss the ball in that first week? 1, steroids at the right time in the right patient. 2, anticoagulation, pulmonary support, remdesivir, maybe if we're still in the first 10 days, immune modulations, consider tocilizumab, avoid those unnecessary antibiotics and unproven therapies. All right, we actually have quite a bit today on the late phase, the long COVID, the PASC section. And I know they've supposedly debunked long COVID up at the MGH, and even when it happens, it is supposedly one's own fault for being overweight and out of shape. But humor me if I continue to believe my patients that are continuing to suffer. I will remind our listeners that when they first proposed written examinations for the Harvard Medical School, the head of surgery protested, letting Dean know that he only estimated 15% of the current class at that time was able to read and write. Yes, they have come a long way up in Boston from the days when no academic preparations were required, no written exams were mandatory. Students did not pay tuition. Instead, they bought tickets to each lecture. I'll leave in a link. But let me get to the article. The article, Serological Response to Vaccination in Post-Acute Sequelae of COVID, recently published in BMC Infectious Disease. Here, the investigators performed a prospective study where 245 adults clinically diagnosed with PASC and 86 adults successfully recovered from prior COVID were vaccinated and had serology testing performed. Individuals with PASC mounted consistently higher post-vaccination IgG spike antibody levels when compared to the COVID recovered, with similar results seen for ACE2 binding levels. The post-vaccination IgM response in PASC was actually attenuated, but persistently unchanged over time compared to the COVID recovery folks, wherein the IgM spike response expectedly decreased over time. I thought this IgM drop was rather interesting. So actually pasted in the figure here. So sort of curious, Vincent. Maybe our immune colleagues have some ideas.
IgM drops anyway, right? At some point, replaced by IgG. So,
yep.
I don't know what that means here.
Yeah, I'm not sure what the mechanism is here. It's interesting that there's, these people who are malingering, as we now know, can somehow have an immunological distinction here. So. All right, the article, Sex Differences in Cardiovascular Complications and Mortality in Hospital Patients with COVID-19 Registry-Based Observational Study, was published in BMJ Medicine. These are results of a registry-based observational study, 74 hospitals across 13 countries participating in this capacity COVID trial, cardiac complications in patients with SARS coronavirus to registry. So pull some letters out of there. It's interesting. From March 20 to May 2021. Of the 11,167 adults reported cardiovascular complications. We were seeing supraventricular tachycardias, pulmonary embolism, heart failure. So just more evidence that getting COVID is not such a safe way to get that immunity against reinfection. And the article, Association of COVID-19 Vaccination with Risk for Incident Diabetes After COVID-19 Infection, was published in JAMA Network Open. This seemed to get a lot of attention. People do not want to get diabetes. These are the results of a large cohort study of adult patients with one or more COVID-19 infections treated within the Cedars-Sinai Health System in Los Angeles, California from March 2020 to June 2022. Rates of new onset diabetes, hypertension, hyperlipidemia, and benchmark diagnosis occurred in the 90 days after COVID-19 infection were higher than those before infections, with odds post-infection for diabetes 2.35, hypertension 1.54, benchmark diagnosis 1.42, hyperlipidemia 1.2. Also, the diabetes risk after infection was higher among the unvaccinated, odds ratio 1.78, while with vaccinated, it was just barely 1.07, so just barely elevated. So another reason why it's a good idea to get vaccinated before you get that infection.
Daniel, have you seen this, and is it treatable with insulin?
So it tends to be type 2. So usually you're starting with metformin, some of the oral agents. But yeah, we're certainly seeing new onset diabetes after, and here, as you can see, we see diabetes, but now we're seeing an odds ratio that there's actually an association here.
And does it persist? So this is a long COVID symptom, basically, right?
It's interesting. This would fall under, I think, why they call it post-acute sequelae of COVID, because this doesn't fall into that classic long COVID, fatigue, brain fog.
Mm-hmm.
This is, I think I'm doing better, but by the way, my glucose is now in the 190s, and I'm having to start medicine for that. All right. The article, Post-Acute Sequelae of SARS-CoV-2 in University Settings, was recently published in Emerging Infectious Diseases. I have to say, this is usually one of my favorite journals out there, but I am going to be a little critical here, and maybe this prompted that Steinbeck quotation up front. So in this study, the George Washington University COVID-19 Surveillance and Testing Program identified 4,800 COVID-19 cases during August 2020 through February 2022. COVID-19 positivity at George Washington University was determined on the basis of PCR tests that were performed in the George Washington University Clinical Laboratory Improvement Amendments or Clinical Laboratory Improvement Amendment Certified Public Health Laboratory. Other cases were identified through results uploaded to the person's medical portal from external positive tests, either PCRs from an external Clinical Laboratory Improvement Amendment Certified Laboratory or self-administered antigen tests. That was about 1,572. Only antigen tests approved for emergency use under the FDA EUA were accepted, so far so good. During July 2021 through March 2022, all 4,800 positive COVID-19 test results reported during this period were followed up with confidential electronic surveys sent to each patient at least 28 days after their initial positive result that included questions about long COVID, so they say. They defined long COVID as experiencing greater than one of the following symptoms lasting for greater than 28 days after a respondent's 10-day isolation period ended. Difficulty driving, difficulty having conversations, difficulty making decisions, difficulty thinking, fatigue, feeling anxious, feeling depressed or sad, loss of smell, loss of taste, memory loss, muscle pain, muscle weakness, shortness of breath, or difficulty sleeping, trouble sleeping, worsening of symptoms after physical activity, worsening of symptoms after mental activity, or other symptoms, just in case we missed something. In addition, respondents were considered to have long COVID if they reported still experiencing COVID-19 related symptoms at the time of the long COVID survey. So here we are already getting in lots of trouble. I think they also included anyone who wears shoes just to make sure they had Now they report only getting a response rate of 31.8%, so about 70% just didn't even respond. And then report that using this very vague inclusive definition of long COVID, that the prevalence of long COVID herein defined is 36%. So what do you think, Vincent? I'm shaking my head just like you are.
First of all, is it really useful to use a different definition of long COVID from, say, what WHO has established and is much longer. It's not, right? And so you have all these things that are lumped in there that many people feel that I don't think are specific because they're probably mostly going to go away. And as you say, the response rate is low. So this is just a bad study, Daniel.
Well, what I think is troubling, and this is why I started with my Steinbeck quote, is that this is being promoted as, see, long COVID can even be
Yeah.
a significant problem in young, healthy college students. And I'm looking at this and saying, this is unbelievable. You're going to try to tell people that 36% of young, healthy college students that got COVID now have long COVID. And people are going to say, you know what, that's just not true. Lie to me once, I'm the fool, lie to me twice, etc. And so you can't promote something like this. This is a study which actually undermines, I think, confidence and faith. This is just, I'm sorry to say, this is a terrible study. All right. And there actually is an article in the Wall Street Journal, the CDC's Long COVID Deception by Alicia Finley, that is properly critical of this article. Physicians and scientists should have the proper training to read this article for themselves. I suggest they do that before pontificating about the results. But for the broader audience, Alicia Finley does a great job. She points out that this study suffers from methodological problems, no control group. She also picks up on the poor definition of long COVID, making it so expansive that I'm surprised so many people did not get labeled as long COVID sufferers. I'm actually surprised that Vincent. I go through this list. I'm feeling a little anxious actually. So, anyway, I won't list all the problems I'm seeing in that list that I could check off. But let me quote the last bit of the article. By exaggerating the incidence of long COVID among young, healthy adults, the CDC deflects attention from the mental health problems caused by misconceived pandemic policies. It also fuels public distrust in the scientific enterprise, which may prove to be the pandemic's most destructive long-term effect.
I think that last part is the most important, because then you have all this garbage science coming out and people say, how can we trust any science if so much of it is garbage like this one? And I don't blame them, right?
Yeah. All right. So as I like to close, looking out in the entire world, not just being so U.S. centric, no one is safe until everyone is safe. And as we've seen, access to vaccines, access to therapeutics is still limited throughout the world. But let me close with the New York Times article, Podcast Companies Once Walking on Air Feel the Strain of Gravity. It is an interesting article, but what I took away was that podcasting is still in a growing phase with increasing demand and another 20% increase in downloads from last year. So, Vincent, should we worry?
Well, I always worry, Daniel, but most podcasts are probably not worth continuing, and that's why the strain of gravity is affecting them. Now, ours, on the other hand, are important. We're reporting science to you, which you can't get anywhere else. So I would say that we have a good future.
All right. Well, our future is, of course, dependent on our listeners. So I do want everyone to pause the recording right here. Go to parasiteswithoutborders.com and click donate. Even a small amount helps us continue to do our work. And we are now in the middle of our American Society of Tropical Medicine and Hygiene fundraiser. So during the months of February, March, and April, donations made to Parasites Without Borders will be matched and doubled up to a potential maximum donation of $30,000 from Parasites Without Borders to American Society of Tropical Medicine and Hygiene.
It's time for your questions for Daniel. You can send them to daniel@microbe.tv. Stephen writes, a friend of about 70 lives with lupus, was hospitalized with anaphylactic shock after receiving her first Moderna vaccine dose. She's not received any other COVID vaccine, and though she has been sick and a cancer patient, she's not had COVID as far as she's aware. What do you recommend? Well, I don't think she's inclined to pursue COVID vaccination in light of her first experience. I wonder, were she to consider, say, Novavax, is there a test an allergist or immunologist could do to know whether she's likely to have an allergic reaction? And would you recommend she have serology done? Too bad Evusheld is no longer effective.
Yeah, so these are some great questions. And, first my heart goes out because there's a lot of people in a situation like this. And so the first is this is great that we have a different platform as far as an opportunity for vaccinations. This is a great time to be looking at Novavax. And it would make sense for her to work with an allergist who can actually do PEG testing and really confirm that that was the trigger, that was the issue. So that would be number one. Get involved with an allergy immunology specialist who has knowledge and expertise in this area. We have some great ones that I've worked with here in the New York area who've done such testing and then allow people to safely go on and get a Novavax vaccine. The next is, as we always talk about, have a plan, right? I'm not a big fan of checking those serology tests. But if this person does end up with a positive test, you want to know ahead of time what are their medications? What is their renal issues? Can they end up on Paxlovid? Do we need to be having a plan where they get remdesivir? So that's a big thing for this person. Look at potential vaccination, but also have a plan.
Kevin writes, does severity of the early viral upper respiratory non-hypoxic phase predict the early inflammatory lower respiratory hypoxic phase? I was seeing a patient with a history of heart failure on amiodarone and Eliquis, got primary vax series plus booster. His family member was COVID positive, so he took a COVID test. It was positive. He has no symptoms other than increased sneezing. No fever, sore throat, etc. Vitals normal. Previously got antibodies with his last COVID infection, but can't get them now. Ended up with molnupiravir as outpatient. Remdesivir isn't a thing where I am. Got me thinking, though, what's his real chance of him ending up admitted on oxygen a week later? It seems that lack of symptoms in the URI phase would make it unlikely that he progresses to a hypoxic phase, but I'm not sure. And would Paxlovid prevent progression in someone like him if he didn't have med contraindications? I think the EUA for Paxlovid is for treatment of mild to moderate disease, but how about asymptomatic disease that is less than mild?
Yeah, so this is that interesting. There's really two questions here, and one is, these different medications, therapeutics are authorized for treatment of COVID-19, not just treatment of a positive PCR, positive antigen test. So that's important. The other, and this is a challenge, right? And I worry about this because what a lot of people do is let's just see how you do during the first few days, because for some reason they're hesitant to actually jump in and treat this. And we know the earlier you treat it, the better. So there really shouldn't be much of a scenario where you're waiting to see how those symptoms are during the first few days. There might be the rare exception where you're like, boy, there's going to be a significant risk benefit here. But there's a challenge. I don't think we have great data where we can say, oh, just because your symptoms were mild during that first week, that's going to mean you're not going to have that significant early inflammatory surge, that cytokine storm. And unfortunately, you can't go back.
James writes, I've been listening to your podcast for a couple of years now. Every week you reiterate that young people are also at risk from COVID. I live in Australia, have two children ages 2 and 5. As of right now, my 5-year-old is only legally allowed to have 2 doses of mRNA vaccine, and my 2-year-old is still not legally allowed to be vaccinated at all. The governing body in Australia has deemed that vaccines in the under 5-year-old population is only available for extremely immunocompromised kids, and he provides a link for the guidance. It's been about 6 months since this guidance was originally given, which was also months after approval was granted in the U.S., and a lack of safety data seems to be the continued line that the committee has taken on not allowing these vaccinations. As a parent of a 2-year-old and an under-vaccinated 5-year-old with no booster yet available, my family has been desperate for any kind of protection that we can get for our child. Would you also agree that giving parents the choice to vaccinate their under 5-year-olds at this stage to be the safest and wisest option for the powers that be in Australia, taking into account the possibility of severe disease, hospitalization, long COVID, long-term effects on a child's immune system? I would be more than happy if this question was to make it on the air to raise the profile of this issue within the medical establishment in Australia.
Yeah, we've covered this countless times, and I do appreciate you raising this. Pediatric deaths are rare, but we have seen here in the U.S., over 1,000 pediatric deaths, and that is really shocking because kids usually don't die, once they make it through the first few days of life. I have to say here in the U.S., they really tend not to die very much. But the other thing is tens of thousands of hospitalizations. I mean, this is a high risk. If a kid ends up in the hospital, that's traumatic for them and the parents. It's not great. that's a severe outcome. It is so much safer to go forward with vaccination than it is to go forward with getting infected. And that's really the choice at this point. And here in the US, we say 97% of our children, probably more at this point, have been infected. Really, the question was, do you get a vaccination series in before that happens? And yeah, the 3 shots make sense. So yeah, this is tough. I mean, what do you want people like traveling from Australia to the US just so they can, have access to evidence-based measures?
Come on, Australia, get with the program. Do the right thing for your kids. That's TWiV, Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.